Right, so we can begin. We are going to talk about congenital heart defects. Remember, this is just in continuation of what we started on the cardiovascular series of lectures. We had talked about anatomy of the heart, anatomy of the vascular system. We agreed on what you need to read under the vascular system. We talked about how blood flows through the fetus, what we call fetal circulation. We looked at the cardiovascular changes which occur when a baby is born. We saw some unique features about the fetal cardiovascular system when we compare with the postnatal type. To sum up that story, we are going to look at congenital heart defects. These are malformations that either affect the wall of the heart or they affect the valves of the heart, or they may affect the major blood vessels that connect to the heart chambers. When you talk of the major blood vessels that connect to the heart chambers, we are referring to the pulmonary trunk, to the aorta, or to the two vena cava, superior and inferior vena cava. Well, also the pulmonary veins as well. So basically, either the vena cava, the pulmonary veins, or the two outflow tracts, which are aorta and pulmonary trunk. Those are the major vessels we're looking at. So the spectrum of malformations that we're going to talk about affect those three entities of structures. Congenital heart defects can actually be asymptomatic. Sometimes a baby is born and you don't know that they have a congenital heart disease. And some of them can actually even be asymptomatic almost throughout life. That means that that's not what will really kill them. They may not be symptomatic at all. Yet some of them are not even compatible with life. A number of them actually, a child will be born already dead because they're not compatible with postnatal life. Having said that, it's a wide spectrum. It means that even in terms of clinical presentations, some congenital heart defects will present when a baby is born, but some of them can even present in childhood or even adulthood. It is important to note that we can even classify congenital heart defects based on whether that congenital defect allows mixing of the two streams of blood. I hope you remember that there was what they call the oxygenated stream and the deoxygenated stream. Well, in adults, we have those two streams. Postnatal life, sorry, we have those two streams. The oxygenated stream of blood and the deoxygenated stream of blood. So you and I know that when you talk of the oxygenated stream of blood, we are referring to the pulmonary veins, the left heart chambers, and the arteries. Those ones carry oxygenated stream of blood. When you talk of the deoxygenated stream of blood, we're referring to the veins, the right heart chambers, and the pulmonary arterial system. So there's some malformations that allow those two streams to mix. And there's some malformations that don't allow those two streams to mix. Yes, there's a malformation, but those two streams don't mix. So now, what do we need to learn here? We are going to look at how we classify congenital heart anomalies. Just an overview of how we classify them. We're also going to explain the implication of what we call a right to left shunt. We're also going to look at the implication of what we call a left to right shunt. Those are some of the terminologies we use when we classify congenital heart diseases. From a clinical point of view, there's some congenital heart diseases that present with cyanosis. So we're going to see which ones are these that we call cyanotic congenital heart diseases because they present with cyanosis at the time of birth. And we're going to see why do they really present with the cyanosis. Maybe before we proceed, someone need to tell me something. Let's see who. Okay, Adelida, I'll start with you. You're in. Adelida?
Yes.
Okay, Adelida. Adelida, what is cyanosis? Any idea?
Not sure.
Okay. Cyanosis is the bluish discoloration that someone can have because they have a lot of carbon dioxide in the circulation. So if the blood is deoxygenated, someone will turn bluish. That's what we call cyanosis. Adelida, have you understood?
Yes.
Okay, great. So that these malformations that we call cyanotic, which means that the baby turns blue at the time of birth. In high school, you may have called this one the blue baby syndrome or something close to that effect. Then there are those malformations where the baby does not turn blue. So we call them acyanotic. Those ones are so many, we can't exhaust the list. So I'll just highlight to you the commonest ones. We are also going to see why the baby does not turn blue in that case. So let's start with the first agenda there, which is how to classify congenital heart diseases. This is how we classify congenital heart diseases, and there could be other ways in which they're classified. But from an anatomical point of view, I prefer this one. From a radiological point of view, there are other classifications that we can use. But now I'm not training you as radiologists. We are in an anatomy class, so we will classify it anatomically and perhaps physiologically. So we classify them into two. We call them shunt anomalies and the non-shunt anomalies. Akecha, are you in? Geraldine?
Yes.
Okay, Geraldine, you'll increase your voice a bit. What is to shunt?
A shunt is an opening.
Okay, I agree with you. It's an opening. In this context, in the cardiovascular context, when we talk of the term shunt, what does it mean?
There is an opening where it is not supposed to be.
Okay, maybe that. So this, remember from our terminologies that we used when we're describing fetal circulation, to shunt is to bypass, to skip. So yeah, I agree with you. There's an abnormal vascular connection that is trying to bypass some circulations. Now, in this case, when you use the term shunt, it means an abnormal connection that tries to connect oxygenated and deoxygenated stream. Or simply put, malformations that we call shunt anomalies are malformations that allow mixing of the oxygenated and the deoxygenated stream. If we understand it that to shunt is to bypass, therefore you realize that there are two circulations that can be bypassed if you have a shunt. Asma, are you in? Asma?
Yes.
Okay, Asma. So tell me, which are these circulations that can be bypassed in the postnatal life? Asma, carry on. Asma, umeniacha kama hivyo. Okay, so either blood can bypass the systemic circulation or it can bypass the pulmonary circulation. So any malformation that make us skip the systemic circulation or make us skip the pulmonary circulation is called a shunt anomaly. Those shunts will allow mixing of oxygenated and the deoxygenated streams of blood. The ones that don't allow mixing of the two streams are therefore called non-shunt anomalies. With that in mind, therefore, we further classify the shunt anomalies into two. We have what we call the right to left shunt, and we have what we call left to right shunt. I want you to understand what it means by the term right and what it means by the term left. Florence, are you in? Florence?
Yes, yes, I'm in.
Okay, Florence, tell us the right side of the heart, which kind of blood does it contain? Oxygenated or deoxygenated?
Deoxygenated.
Very good. I didn't want you to think about that one. The right chambers of the heart contain deoxygenated stream of blood. So we use the term right to mean deoxygenated stream of blood. We use the term left to mean the oxygenated stream of blood. Therefore, when you have a right to left shunt, it means that deoxygenated blood goes to the oxygenated blood. And when you have a left-right shunt, it means that oxygenated blood is going to the deoxygenated stream. Fred, are you in?
Sir, pardon, please.
Okay, Roylin, I'll repeat. The term right, as Florence has just told us, the right chambers of the heart contain deoxygenated blood. However, we use the term right to mean deoxygenated stream of blood. And we use the term left to mean the oxygenated stream of blood. So when we say this is a right to left shunt, it means that blood is moving from the deoxygenated stream to the oxygenated stream. You have an abnormal channel that makes blood to move from the deoxygenated to the oxygenated side. And if you have a left to right, it means that you have an abnormal connection that is causing blood to move from the oxygenated side to the deoxygenated side. Rolene, have you understood?
Yes, thank you.
Great. So Fred, I was on your neck, kidogo. Fred, are you in?
Yes.
All right, Fred, tell us. So if you have a right to left shunt, which circulation is that blood skipping?
Sorry.
Sorry?
The question.
Fred, we are asking if you have a right to left shunt, which circulation is that blood skipping? Fred?
Pulmonary circulation.
Okay, great, great. So right to left shunt skips the pulmonary circulation. it means that blood does not go to the lungs. That blood moves from the right chambers to the left chambers without going to the lungs. If you have a left-right shunt, it means that we are skipping the systemic circulation. The blood moves from the left chambers to the right chambers without going to the systemic circulation. Okay, now to make sure you've understood that, because I think this is important, Johnny, I want to ask you a question. Are you in?
Yes, I'm in.
All right, Johnny. My question to you is, blood within the pulmonary artery, is it a right or a left structure?
Sorry?
The pulmonary artery,
Yes,
would you term it as a right or a left structure?
a right structure.
Very good. So it means you are getting it. Great. So with that in mind, therefore, we want to explain the implications of having a right to left shunt and also implications of having a left to right shunt. Before that, maybe I give you a question. Jemutai, are you in?
Yes.
All right, Jemutai, this is your question. I believe you can see it. You can tell us what you think.
Left to right.
Okay, why do you think left, right, Jemutai?
Because when deoxygenated blood moves to the right, then it goes to the body tissues.
Okay,
That will
okay, I like your explanation, but what you're explaining is different from what you've said. You're worried that if deoxygenated blood goes to the systemic circulation, that is not a good thing. Which of these will actually make deoxygenated blood to go to the systemic circulation? Jemutai, back to you. Jemutai, carry on.
which one will make deoxygenated blood to go to the systemic circulation?
Yes.
Left to right, or right to left.
Right to left, because right is deoxygenated.
Yes.
So if you have a right to left shunt, it means that deoxygenated blood is going to the systemic circulation. Jemutai, I want to make sure you've understood what you're saying. So I'll still ask you a question. So if a baby has a right to left shunt, how will they present clinically?
They'll be bluish.
Very good. Now you've understood. Great. So that means what? If a baby has a right to left shunt, they'll turn blue. And for that reason, the right to left shunts are known as cyanotic congenital heart diseases. On the other hand, the left-right shunts just make oxygenated blood go back to the lungs. So the baby will not turn blue. Therefore, they are not cyanotic. We call them acyanotic congenital heart diseases. Similarly, the non-shunt malformations are unlikely to present with cyanosis. Therefore, they are also acyanotic congenital heart diseases. So this classification is a clinical classification. Cyanotic congenital heart diseases are the right to left shunt. Then everything else is a cyanotic congenital heart disease. Now, maybe I need to put a warning, kidogo, that when we classify them as cyanotic, it doesn't mean that this baby will never be cyanotic. The only issue here is that at the time of birth, they may not be cyanotic. But as they go on, maybe if the anomaly was so severe, it can make them have cyanosis for other reasons. But at the time they're being born, they'll not present cyanosis. So cyanosis in these other babies may come a secondary factor, either due to an infection or something, maladaptation. But at the time of birth, they'll not be cyanotic. I think this is a bit unfair question to you. So let me not ask it. Let me skip it. The reason is because I don't think you've understood these ones. So let me just explain them and put this to the upgraders. For them, I expect them to understand it because they've done this before. For you people, you'll slaughter me if I force you to know this at this point. But maybe as we go on, you're going to answer that question. So let's look at the congenital heart diseases that we classify as being cyanotic. Have it in your mind that these cyanotic congenital heart diseases present with, or rather, whatever we are calling cyanotic congenital diseases present with bluish discoloration at birth. And they do this because they have a right to left shunt. So the cyanotic congenital heart diseases that we are going to look at this point have a right to left shunt. So it's our duty to then look, where is that shunt and why is that shunt happening? The first one is what we call tricuspid atresia. Joy, are you in?
Yes.
All right, Joy. What's the meaning of the term atresia? Any idea?
No.
Okay, the term atresia means blocked. Don't confuse, there's some two terms that you need to know. The term atresia and the term stenosis. Stenosis means narrow. Atresia means blocked. When you did the cardiovascular system, I told you can even have some congenital anomaly. When we did the respiratory system, we talked about bronchial atresia. It means blockage. Joy, I'm still with you. So look at this patient, Joy. We see that the tricuspid valve is blocked. Joy, what do you think will happen to blood when blood comes to the right atrium if the tricuspid valve is blocked?
The blood will not go to the right ventricle.
Very good. Where do you think the blood will go?
To the...
Okay, let me make it easier for you. So blood will go to the left atrium via the foramen ovale. Why is it that, Joy is still on you, why is it that if the tricuspid valve was open, blood will not move from right to left through the foramen ovale, but now that the tricuspid valve is blocked, blood moves from the right to the left atrium? I have a feeling it's a bit of an unfair question to you. Maybe anyone can answer.
Can I?
Yes, Jemjai, you can.
Now the pressure, the pressure.
Yes.
The pressure on the right ventricle will be lower.
Yeah, the pressure, like, yes, so?
Then blood will move from the right atrium to the right ventricle. So that's the reason why it will not go to the foramen ovale.
Okay, I get your point. So, but you've not answered the other part, but it's okay. We can now make inference. You're right. If the tricuspid valve is blocked, blood in the right atrium will be at a higher pressure than blood in the left atrium. In that case, our foramen ovale will not close. I hope you remember the concept of physiological and anatomical closure of the foramen ovale. So now in this case, the foramen ovale will not close. That means that now blood in the right atrium will move to the left atrium because the pressure of the right atrium is higher than the pressure of the left atrium. Therefore, if blood moves from the right atrium to the left atrium, you have deoxygenated blood going to the oxygenated stream. That is a right to left shunt. That is why we call that cyanotic congenital heart disease. Let's look at the second one. This is what we call persistent truncus arteriosus. Now, truncus arteriosus is a common vascular channel that gives rise to the ascending aorta as well as the main pulmonary artery. In the heart, what usually happens is that a septum needs to form between the aorta and the pulmonary trunk. We can call that septum the aorticopulmonary septum or the conotruncal septum. It has many other names, don't worry about it. Just know that there's a septum that splits the truncus arteriosus into two, ascending aorta and the pulmonary trunk. Now you need to note that that septum is not a direct septum like this. No, that septum has a spiral outline. That is what makes the aorta, even though it's on the right here, to arise from the left ventricle. And the pulmonary trunk, even though it's on the left here, it will come from the right ventricle. Because the septum that splits the truncus arteriosus has a spiral outline. It's not as direct, it's not a straight septum. Now, there's some malformations that can occur due to abnormal septation of the truncus arteriosus. And one of those malformations is this one. If the septum fails to form completely, we call that persistent truncus arteriosus. If that be the scenario, then it means that the aorta and the pulmonary trunk have a common channel. Right. Mariam, are you in?
Yeah, I'm in, sorry.
All right, Mariam. So look at this. So blood here. Okay, let's start with this one. Blood in the left ventricle can go to the truncus arteriosus and find its way there. My question to you is this: is that normal or abnormal?
Sorry, it finds its way to the truncus arteriosus.
It will follow the cursor. So blood can be from here, then it goes to this region there, truncus arteriosus, then it goes here.
That's normal.
That's normal. Very good. I'm still with you. Blood from here can go here and then find its way there. Is that normal or abnormal?
Abnormal.
Very good. What is abnormal about that one?
Because it's going to the pulmonary artery, but it's already oxygenated.
Very good. So it's a shunt. Which shunt is it?
The ductus arteriosus.
No, in terms of right to left, left to right.
Oh, sorry. Left to right.
Very good, very good. I'm glad you picked that. So blood from here can find its way there, and that would be a left to right shunt. That does not give you cyanosis. Similarly, blood from here, right ventricle, can find its way there, up to there, and that's normal. The problem arises if blood from here enters there, then find its way there. That will be the problem. That will give you a right to left shunt. So you need to understand that in persistent trunk ascites, either ventricle can take blood to any of the outflow tracts. Therefore, persistent trunk ascites has both right to left as well as left to right shunts. But of course, from a clinical point of view, we know that deoxygenated blood is going to the systemic circulation. So this baby will still turn blue. That's why we classify it under cyanotic congenital heart diseases. Great. All right. So Mercy, you are next. The third clinical entity is what we are calling tetralogy of Fallot. This T is silent, so you call it Fallot, not Fallot. Okay, in tetralogy of Fallot, this is the problem, that the septum that is supposed to separate the trunk ascites forms, yes, unlike the previous condition, but the problem in this case is that the septum does not form in the middle. So the end result is that we have a very large aorta and a very narrow pulmonary trunk. So I want you to understand that the issue here is that the septum that is separating the trunk ascites has not formed in the midline. So we have a very narrow pulmonary trunk and a very wide ascending aorta. This one gives us 4 malformations in one, and that is why we call it tetralogy. Tetra means 4. So there are 4 disorders that occur because of what I've just told you. One of the disorders is this, that the aorta is so wide that it is arising from both left and right ventricle. And that is what we call overriding aorta. The second problem is this, that the pulmonary artery is so narrow. So narrow pulmonary artery is what we're calling pulmonary artery stenosis. If the pulmonary artery is narrow, then what happens is this, that the right ventricle will struggle to pump blood through the pulmonary artery. So it means that the wall of the right ventricle will become thick because it has to pump blood through this high pressure. So with the time, the right ventricle will become thicker, and that is what we're calling right ventricular hypertrophy. The fourth problem is that the septum that is separating the right ventricle and the left ventricle will not be complete, because ideally this septum is supposed to be continuous, the septum separating the 2 vessels. But if this one is not in the middle, then there'll be a defect, what we call ventricular septal defect. So we see 4 malformations, 4 problems, just because the septum separating the truncus arteriosus did not form in the middle. So that's why we call this tetralogy. Now, Mercy, this is your question. Are you in?
Yes.
All right, Mercy, ongeza kasauti. So, Mercy, where is the right to left shunt in this patient? Why does this one give us cyanosis?
In my opinion,
Yes.
because of the blood, there isn't a septum between the 2 vessels. So the blood coming from the right ventricle,
Mhm.
it is deoxygenated,
Mhm.
and then when it reaches the pulmonary artery,
Mhm.
it will mix with the ascending aorta.
Okay, you're partly right, but I understand why you say whatever you're saying. So the concept is that blood in the right ventricle is actually entering the aorta. Because we've said that you have an overriding aorta that is receiving blood from both ventricles. Remember, the septum between the pulmonary trunk and the aorta is intact. It's not affected. The septum is there, except not the midline. So in this case, the aorta receives blood from both ventricles. What gives you cyanosis is this one, that the right ventricle takes blood to the aorta as well. So that will give you right to left shunt. I want you people to understand that tetralogy of Fallot is the commonest cyanotic congenital heart disease. We will expect you at some point in your clinical practice to make a diagnosis of TOF. Please don't miss it. You might be the only person that will be able to save the life of that baby by making the correct diagnosis at birth. It is the commonest cyanotic congenital heart disease. Okay. The fourth cyanotic congenital heart disease I want to talk about is what we call transposition of the great arteries. Fares, are you in?
Yes.
Okay, Fares. I always get excited when I hear your voice, Fares. Great. So, Fares, look at the image here and tell us what is the problem in this heart? What's the problem? Can you see a problem, Fares? Okay, Fares, now you refuse to talk. After I got happy that you are talking. Okay, now you can talk, yes. Fares? Okay, anyone who sees a problem in this heart?
Can I try?
Yes.
There is a problem with the positioning of the
Sorry, Tony.
arteries, like the outer is picking blood from the right ventricle.
Very good.
I'm saying the problem positioning of the arteries, the outer is picking the oxygenated blood from the right ventricle, and the pulmonary artery is collecting blood, oxygenated blood from the left ventricle.
Very good. Thank you, Tony. You've picked it correctly. Now, this problem arises from the fact that the septum that's supposed to separate the truncus arteriosus that fails to have that spiral line. The spiral outline is not there. The septum is there, yes, but it does not spiral. Remember, I told you need to spiral so that the aorta comes from the left and main pulmonary artery comes from the right. If it fails to spiral, the aorta will come from the right and pulmonary artery from the left. As Tony has told us, So we have abnormal origin of the roots of the great arteries. The great arteries in this case being the ascending aorta and the main pulmonary trunk. They have abnormal origin, as you can see here. That the ascending aorta is from the right ventricle instead of left. And main pulmonary artery is from the left ventricle instead of right. That's why we call it transposition of the great arteries. Rosmarion, are you in?
Yes.
All right, Rosmarion, look at this. So blood is moving from here to there. Is that a shunt? And if it is a shunt, which shunt is it?
It's supposed to be a shunt.
Okay, which shunt?
Left to right.
Very good, very good. So yes, that is a shunt and it's a left to right shunt. That will not give us cyanosis. What will give us cyanosis is this one here, that you have a right to left shunt. That is what will give us cyanosis. Now this clinical condition is not compatible with life, not compatible with life, unless the ductus arteriosus is patent. And so one of the things that you'll do to these babies, if you want them to be alive, is to first make the correct diagnosis of TGA. Once you've made the correct diagnosis of TGA, then there's a drug that can be given. That drug is prostaglandin E1. By delivery of that drug, the ductus arteriosus does not close. If the ductus arteriosus fails to close, it means that this baby can still be served through the ductus arteriosus. Now remember from what we said last time, cardiovascular changes at birth, that the ductus arteriosus closes physiologically within the first few days, 3 to 7 days. You have to give that drug within those days until that baby receives surgery to correct the TGA. So you'll again be saving life if you make that correct diagnosis of TGA. Right. This is what we call total anomalous pulmonary venous connection. Now follow with me. These are the pulmonary veins. The left pulmonary veins, the right pulmonary veins. They seem to connect to the superior vena cava. Okay, Roylin, you're in?
Yes.
Okay, Roylin, so pulmonary veins go to the superior vena cava instead of going to the left atrium. Which kind of a shunt is that?
Okay, oxygenated blood is moving to the deoxygenated left to right.
Very good. So that's a left to right shunt. Now, we are still with you, Roylin. So blood has moved from the pulmonary veins to the superior vena cava, and I agree with you that is a right to left shunt. That blood mixes with the deoxygenated blood here, and everything is within the right atrium. When blood reaches the right atrium, it will go through foramen ovale to the left atrium. So Roylin, your last question is this. What makes blood to move from the right atrium to the left atrium in this particular case?
I think the oxygenated blood is normally in high pressure. So I think when it mixes, it increases the pressure. a little bit and maybe. That's what I think.
Okay, the oxygenated blood usually is in high pressure, I agree with you, but what makes it have high pressure is not the oxygen in it. It is about the volume of blood. In this case, look at the left atrium. There is no vessel that is going back to the left atrium. When we're talking about cardiovascular changes at birth, we said that the pulmonary circulation opens up and blood enters the left atrium, and that makes the left atrium have high pressure. So if there is no blood vessels emptying into the left atrium, it means that the left atrium will remain with lower pressure. In that case, foramen ovale will not close. And that is why blood from the right atrium moves to the left atrium. Okay, now I want all of you to see this. Remember, this blood is oxygenated. It will come to here, and then it may find its way back to the left atrium. And there's nothing wrong with that blood coming from the right atrium to the left atrium. As a matter of fact, it is oxygenated. So it's going to where it's supposed to be. The problem is that you will not just filter the oxygenated blood only in the right atrium to go back to the left atrium. Even the deoxygenated blood will now move to the left atrium. And that is what will give you now the right to left shunting. The deoxygenated stream, which is from the brain or from the lower limbs, will now enter again through foramen ovale to the left atrium, and that is what will give you a left to right shunt. So in total anomalous pulmonary venous connection, all the 4 pulmonary veins fail to empty into the left atrium. Instead, they empty into the right atrium. It could be direct or via the superior vena cava, as we can see in this particular condition. And that is why we are calling total anomalous. We call total anomalous because there's also partial anomalous pulmonary venous connection. The partial anomalous will not give you cyanosis because the left atrial pressures will still be normal or high. So as I've explained to you, there'll be a left to right shunt first, then a right to left shunt at this point. And that is why this will give you cyanosis. I want to add a last one on cyanotic congenital heart diseases, and that is pulmonary atresia. We've already defined the term atresia as blockage. So the pulmonary valve is blocked. If the pulmonary valve is blocked, why would this give you cyanosis? Tony, this is yours now. Tony, are you in?
Yes, I'm in.
All right, Tony. So if we have pulmonary stenosis, why should this give us cyanosis?
So it means the blood will not be moving to the lungs.
True, so?
So, I don't know.
Okay, but I'm glad that you've picked that if you have pulmonary stenosis, blood cannot move from the right ventricle to the lung. Instead, this is what happened. Because blood cannot move, the right chamber pressures will be higher than the left chamber pressures. And if the right chamber pressures are higher than the left chamber pressures, blood in the right atrium will then move to the left atrium through a foramen ovale, which will not close now. So the foramen ovale will remain open, and so deoxygenated blood will enter the left chambers, and that will give you a right to left shunt. Well, blood in the left ventricle will move to the aorta and finally move there through ductus arteriosus, and that will give you a left to right shunt so that this blood can actually go to the lungs for oxygenation. But either way, of course, it's not everything that enters there. So this baby will still turn blue because of the deoxygenated blood that is going to the systemic circulation. Great, so those are cyanotic congenital heart diseases. I've taken my time through them because I want you to understand every one of them. You might be the one making that baby survive by making the correct diagnosis. Now let's look at the cyanotic congenital heart diseases. These ones will be quick. So cyanotic congenital heart diseases are either the ones that have a right to left shunt or the ones which do not have shunt. Let's start with the ones that have a left to right shunt. I have a feeling I said the wrong thing initially. So let me say that again. The cyanotic congenital heart diseases are either having left to right shunt or they are non-shunts. I want us to start with these ones, the left to right shunts. So you can have a left to right shunt if you have a ventricular septal defect. It means there's a defect in the interventricular septum. If you have a defect in the interventricular septum, blood in the left chambers will move to the right chambers because the left chamber pressures are usually higher than the right chamber pressures postnatally. And that is why VSD gives you a left to right shunt. It's one of the commonest congenital heart diseases, actually. VSD is very interesting because with the time, the right ventricle will be struggling. As this baby grows, the right chamber pressures increase as the baby grows. And so it might reach some age where the right chamber pressures are actually higher than the left chamber pressures. When that happens, it means that the shunt will reverse from left to right shunt to now right to left shunt. That concept of shunt reversal in VSD is what we call Eisenmenger syndrome. It simply means the reversal of the shunt. It happens not at birth, but sometime later as the baby grows. So VSD, ventricular septal defect, is a common congenital heart disease. These are some of the things we call a hole in the heart. Together with the ASD, which is atrial septal defect, means that there's a defect between the right and the left atrium. In most cases, this will be occurring at the level of the foramen ovale. Again, a very common congenital heart disease. So remember, VSD and ASD are the commonest congenital heart diseases. These are the ones we call a hole in the heart. Apart from VSD and ASD, we also have PDA, patent ductus arteriosus. It means that the ductus arteriosus did not close. If the ductus arteriosus remains patent, blood will move from the aorta to the pulmonary trunk because the aorta has higher pressures than pulmonary trunk postnatally. It therefore means that you have a left to right shunt. So those are the shunt anomalies which give us the cyanotic congenital heart diseases. I've just picked the common ones. Now let's look at the common non-shunt anomalies, which we still classify as cyanotic congenital heart diseases. I'll just highlight on common ones as well. We have what we call coarctation of the aorta. If you look at this image, you'll see that the aorta is narrow at some point there. So that narrowing is what we call coarctation. A patient with coarctation of the aorta will have collateral channels, like some blood vessels that form, because you see if the aorta is too narrow at that point, then blood from this region cannot go back to the lower part of the body and supply the lower part of the body adequately. That narrow channel is not adequate to serve the lower part of the body with enough blood. So as a matter of adaptation, there's some collateral vessels that will become more prominent to redistribute blood to the lower parts of the body. So with time, you'll see those collateral channels. We see those ones in imaging. But you as a nurse, you can pick coarctation by comparing the blood pressure in the upper limbs with blood pressure in the lower limb. Remember, the upper limbs come from, eventually, from the arc of the aorta. And so those ones will have higher pressures, but the lower limb pressures will be very low. So if you get a patient whose blood pressure in the upper part of the body is high, hypertensive, and lower part low, then you know that they might be having coarctation of the aorta. Another non-shunt anomaly. Okay, let me test this to anyone. I want you people to look at that radiograph. And anyone who wants to try can tell me, what problem do you see in that radiograph? Anyone? And we're looking at anatomical. We're looking at the cardiovascular system. Geraldine, carry on.
I am just trying.
Yes.
Could you say the heart is not visible? Like the left lung is, there is no space for the heart on the left side.
Very good. I want you to think along the same line. Look at the shadow of the heart once again. It is not prominent on the left, I agree with you. On which side is it prominent?
On the right.
Very good.
On the right.
That's a problem. That the heart shadow is more on the right than on the left. We agreed that the heart should be more to the left, 2/3, than to the right, 1/3. But in this case, a bigger part of the heart is on the right instead of left. So this type of anomaly is what we call dextrocardia. It means a right-sided heart. Dextro means right, levo means left. So we can say that the heart is dextro-rotated. I don't know whether you people have studied biochemistry, but they use those terms to mean rotations of some carbon atoms. Dextro-rotation and levo-rotation. Dextro means right and levo means left. So this is dextrocardia, which means right-sided heart. The heart is abnormally rotated to the right, so we call it dextrocardia. There may not really be a big deal with this kind of a person unless now you make a wrong diagnosis of some conditions if the labeling was not there. So these ones will just tend to be misdiagnosed. But interestingly, it can be as bad as you declaring them dead when they're not dead, because you are used to knowing that the apex of the heart is here. So you bring your stethoscope, you put it there, you don't hear heartbeat, oh, we are mekufa. Maybe they're still alive. So maybe those ones, but extremely rare. Look at this one. The heart is exposed. This is what we call ectopia cordis. This comes as a result of a defect of the sternum. The sternum has a problem, actually didn't form, so the heart is just exposed. We call it ectopia cordis. Great. So we have classified congenital heart diseases. We have explained the implication of having a right to left shunt, also that of having a left right shunt. I've given you examples of cyanotic congenital diseases and some few examples of cyanotic congenital heart diseases. So therefore we are done with that lecture. I don't know whether there's a question. Feel free to ask.